MedCram.com.
Hi guys, welcome to another MedCram video. We're going to talk about Mpox, formerly known as monkeypox, in this video, and what has been going on here in the summer of 2024. Specifically, yesterday on August 14, 2024, there was declared a public health emergency of international concern. We're going to talk about what that means and why, and specifically what's going on with monkeypox, or Mpox, it's now known as, currently, as opposed to what's been going on previously, and there's a big difference. So you may recall back in 2022, we discussed the outbreak of Mpox at that time and discussed the signs and symptoms of that virus at the time. And if you want to know more about that and get into detail about the type of virus it is and the symptoms and things of that nature, please reference our videos from 2022 about that. The first thing that you should know is that there are two families of Mpox, and they're known as clades. There's clade 1 and clade 2. Clade 1 is endemic in Africa, and typically it was in the Congo, whereas clade 2 was in West Africa. But more specifically, clade 1 was the more infectious, more likely to cause disease, and was more deadly, up to even about 10% of people who became infected. Whereas clade 2 was less infectious, caused less disease, and was less deadly. It was clade 2b, in fact, that was the type of virus that had spread to the United States and other countries 2 years ago in 2022. And as it turns out, the survival rate was actually 99.9%, very high. Because this clade is less infectious, it takes a lot of contact for this type of virus to transmit. And it was seen mostly in men having sex with other men and other types of very close contact. This is not the clade that is currently the concern. Right now, we have clade 1b, which is making a rise specifically in the Democratic Republic of Congo, but also in neighboring states like Burundi, Kenya, Rwanda, and Uganda. And while it still has the characteristic of being spread through close contact, including sexual contact, because it is more infectious, we're starting to see people having contact, even with people's clothes and bedding, coming down with infections that have never had sexual contact with the index person. Fortunately, we're not seeing a 10% case fatality rate at this point. It's closer to about 1%. We'll go through some data. But this is the clade that is making a rise. And today, on August 15, there was news that somebody from Sweden had actually come down with this version of Mpox, and it was likely because he traveled to that area in the recent past. This is what was declared, this public health emergency of international concern. So I want you to think about this as declaring a state of emergency. What it does, just like in the United States, is it allows for the release of funding and draws awareness that this is what has to be done so it can free up red tape and allow that monies to go exactly where that needs to go. It is a declaration that is made by the WHO and specifically the Director General. And there's 4 criteria, and generally speaking, you need 2 out of the 4 general criteria. Number 1, it's a serious public health threat. It's unusual or unexpected. There's a significant risk of spread internationally. As we've already talked about, it has crossed international borders. And the 4th condition is trade or travel restrictions as a result of this sort of situation. So it's meant to prevent and to direct funds to get the job done. So what is the equivalent of the CDC of Africa looking for to be able to put a lid, if you will, on this? They're actually looking for 10 million doses of the vaccine. Now, we'll talk about that in a little bit about the type of vaccine and how effective that might be. And they're also looking for funding of about $4 billion with a B dollars. To date, they've already gotten about 12 million, which is just a drop in the bucket. The United States just last week promised an additional $10 million, and they're also sending over about 50,000 doses of the vaccine. An interesting development, and we'll talk more about this in the vaccine, is that instead of it being given subcutaneously, that means under the skin into where the fat region is, they're able to give 1/5 of the dose into the skin. So they call it intradermally. So that has already multiplied by 5 the number of doses they're able to give just by giving it differently. And based on the testing that they've done, it looks to be at about the same efficacy. And we'll talk more about efficacy and safety of this vaccine in just a bit. Let's go over some data. This was a paper that was published, and we'll put a link in the description below, at a hospital in the Congo looking at patients that have been hospitalized with Mpox from September of 2023 to April of 2024. There was 371 that were hospitalized and 4 deaths. So we're looking at around 1% mortality rate. 4 out of 8 pregnancies ended in miscarriage. So this virus can go through the placenta. 88% of the patients that were there, and by the way, 52% of them were women, but 88% of them had some sort of transactional sex. That would mean paying for sex at the bars specifically, or areas where there is transportation through the area. However, showing how this is a bit more infectious than the clade 2B, clade 1B in this situation, 3 healthcare workers, just by changing the linens or taking care of the patients, got the disease. Here's some bigger numbers they're keeping track of. About 17,000 have become infected in Africa up to this point this year, and that's about a 160% increase over last year. 96% of them are in the Democratic Republic of Congo, but as we mentioned, there's also cases in Burundi, Kenya, Rwanda, and Uganda. There's been about 500 deaths, which would imply about almost a 3% case fatality rate, but there's probably many of these that are not becoming diagnosed. And here's the real saddening statistic, is that 70% of these above here are children. Why is this? One of the main factors in determining whether or not someone has disease in this infection is if they've been exposed to smallpox before. And that's because smallpox is very closely related to Mpox, such that, in fact, what we saw back in 2003, when there was an animal spread of Mpox in the United States, people that did not come down with the disease had a history, even a remote history, of smallpox vaccination. And so smallpox vaccination has been phasing out. And of course, it's the children that are not getting that smallpox vaccine. These are the ones that are unfortunately in a lot of these statistics. Let's talk about transmission. Small animals is one of the primary ways that this is spread. This virus was called monkeypox because it was first discovered in the 1970s in macaques, which are primates and a type of monkey. However, it's actually very common in smaller animals, mice, groundhogs, all sorts of small animals could have this virus inside of it. And so if they were to bite or scratch, if you were to eat them, wear their skins or furs, or have direct contact, all of these are potential ways. In terms of humans, when the human breaks down with a rash, and generally this occurs after a few days, the incubation period could be about 3 to 17 days in the human being, and the rash usually occurs after a fever of 1 to 4 days. Then when they get these scabs and these bodily fluids and things that come out, that can be contagious. Sex, especially sex that cause these lesions to become open and you were to transmit it, that could do it as well. Respiratory droplets. So this doesn't necessarily mean airborne, but droplets that are large enough to be in contact can cause transmission. And typically it's 4+ hours. So it's got to be prolonged contact. For instance, in a family living in a home, it's going to be easier to spread rather than bumping to somebody on the street. Sheets and fomites, that's important in terms of hospitalization, because if somebody is in the hospital and they're being taken care of, then handling of those sheets can be a vector that could cause infection as well. So what are our options in terms of vaccination? The old type of vaccines that we used to have, and by the way, both of these were actually designed for smallpox and not monkeypox. But because Mpox or monkeypox is so similar to smallpox, these have actually been used and have been found to be somewhat effective. So let's talk about ACAM 2000. ACAM 2000 is an old version. It's a live virus that actually replicates. It's based on the vaccinia virus, which is very similar to both Mpox and smallpox. And when you give the injection into the arm, you actually have to do it in multiple places. So there's multiple infection points that you're putting the virus in there. It's live. And as it starts to infect and cause a sign on the skin that it's actually become infected, that's a sign that there has been a, quote, take. So you need to actually have a take, they call it, to show that the virus has taken hold and has gotten into the system. That is what is going to give you immunity from either smallpox or Mpox. This is a live virus. The other one's a live virus as well, but here's the key. This one actually replicates. Because of the possible terrorist use of smallpox, the United States has actually stockpiled a huge amount of ACAM2000. Unfortunately, there are increased side effects from this vaccine, so it's not the first choice that you'd want to take. Enter this one. This is actually a new vaccine that was introduced, which is also live. So this is not an mRNA vaccine. This is a live virus, also based on the vaccinia. It is attenuated, which means it is somewhat diminished, and it is not replicating. Not replicating. So that means that you don't have to worry about a, quote, take. In fact, this medication used to be given subcutaneously, as we mentioned. It's now being given intradermally at 1/5 the dose. It's one shot that you get, followed by 28 days, and then another shot. So it's 2 shots. It's much more tolerated, much less side effects. Not to say that there aren't any side effects, but they're much more tolerated. The issue, though, in terms of efficacy is that we don't have randomized placebo-controlled trials, and that's because it would be unethical to knowingly randomize somebody to a control arm when you know that this vaccine can actually be beneficial. So what you do in those sorts of situations is you do a case control study that determines what the efficacy would be. The problem is, of course, is that there's a whole host of confounders that can enter in because you don't know if there's other issues where people would be more likely to get vaccinated, would they also be more likely to have better outcomes. So there are ways of trying to get around that and calculate it, but it's not perfect. And I say that because there was recently an article published in the New England Journal of Medicine looking at the efficacy of this vaccine in the United States. And this is the article here. And you can see here that after doing an adjustment, they concluded that using a nationwide electronic health record, patients with Mpox were less likely to have received 1 or 2 doses of Genos vaccine than control patients. The findings suggest that Genos vaccine was effective in preventing Mpox disease and that a 2-dose series appeared to provide better protection. And here you can see the actual raw data in terms of case and control patients. Unvaccinated was 2,022, 6,984, and you can see the rest of those numbers there. The vaccine effectiveness that they found for the partially vaccinated with just 1 dose was actually 52%. And after adjusting for all of the factors, it actually revised down to 35.8%. The 2 doses was found to be around 77% unadjusted, but then adjusted was at just 66%. Even this vaccination is not 100%. It's about 66% effective based on this case control study and looking at adjusted numbers. Now, there was some criticism of this study saying this is kind of a unique population because they used as their control group HIV positive patients that were coming to the clinic to try to counteract the possibility of the healthy user effect, etc. Nevertheless, they tried to do a good control of the data, and this is the best numbers that we have so far for that particular clade that was going through the United States at that time. And that's important to understand because the current recommendation from the CDC, and I'll put a link in the description below, for the recommendations for the use of the Genos vaccine are specifically this, as listed on the cdc.gov website. So Genos is a vaccine listed as a series of 2 administered doses 28 days apart, and it was first made available via the U.S. government during the start of the 2022 global Mpox outbreak. Data collected since 2022 outbreak have found that Genos is safe and effective for the prevention of Mpox. 2 doses are known to be more effective than 1 dose, even when infections have occurred after 2 vaccine doses. They have typically been milder and the infections among people who are not vaccinated. By the way, I'll also note here that this is also indicated if someone believes that they have been exposed to the virus and it's been a couple of days or even longer. You can give this vaccine and it will still have a benefit, they believe. It says here the Advisory Committee on the Immunization Practices recommends the 2-dose Genos series to several populations and for different indications. They say for pre-exposure vaccination of people at risk for occupational exposure to orthopox viruses as an alternative to the ACAM2000. We explain why that would be. ACAM2000 is a little bit different vaccine that's a little bit more aggressive. You need to have a take, and there are some side effects to that vaccine. for pre-exposure vaccination. So that, in other words, if you're going to be working with people who have a high risk of getting Mpox, it may be beneficial to consider doing this. Perhaps you work in an environment where it's highly prevalent and you're going to be taking care of these patients. It might be a benefit to do this. For people who are 18 years and older at risk of getting Mpox during an Mpox outbreak, and they define that even as possibly a single case. For people age 18 years or older with the following risks: gay, bisexual, and other men who have sex with men, transgender, or non-binary people who in the past 6 months have had one of the following. So in other words, they have to have one of the following here to qualify on the list of getting the vaccine. If they've had a new diagnosis of at least one sexually transmitted disease, if they have more than one sex partner, if they've had sex at a commercial sex venue, if they've had sex in association with large public events in a geographic area where Mpox transmission is occurring. In addition to that, it's also recommended for sexual partners of people with risks described above, and for people who anticipate experiencing any of the above in the future. Remember, the efficacy, by the best way that we have of measuring this in terms of a case control study, which is not ideal, shows that the efficacy of this vaccine is not 100%. And that's one of the things that we tried to make clear during the pandemic, is that I believe in the Swiss cheese model. We try to do everything that we possibly can to reduce the transmission of the disease. And there's not one particular thing we should 100% completely depend on. So I think it's important to understand that all of these things increases the risk, and that if somebody were to be vaccinated against Mpox, it certainly would not be a license to engage in risky behaviors if they wanted a 100% assurity that they would not get that virus. So a lot of people ask me, okay, what about the general public? They say currently the CDC does not recommend routine immunization against Mpox for the general public. Jynneos is not recommended as a routine vaccination for healthcare personnel unless sexual risk factors are present. This is not a virus that you want to get. This was an article that was published in 2008 after they looked at the monkeypox from 2003. They actually refer to it here because this is a pretty old paper. And what they found in this paper was actually a little disturbing to me. There is some element in the infection involved with Mpox that prevents T-cell activation. So it acts as an immunosuppressant, and it's not an immunosuppressant specific to Mpox, but just about anything that requires T-cell activation. I will put a link to this article in the description below. So let's review. This is basically declaring a state of emergency from an international health basis. As some have put it, the purpose of this is to rapidly mobilize international coordinating and strategic funding and accelerate the advancements of the development of vaccines and the distribution of those vaccines before this turns into a bigger problem. And that's exactly what's happening. Just like a state of emergency, it's usually based on something that's real. That is the case here. This is different from 2022 in the fact that it's a different clade, it's a different type of virus, even though it's still Mpox. And how is it different? Whereas the previous clade 2B in 2022 was dependent on very close contact, this is not so dependent on close contact. Whereas the 2B clade in 2022 was primarily and almost exclusively sexual contact between men and men, this is a little bit more open than just that type of contact. As we saw with that study, there were people in the hospital, healthcare workers, in fact, that were taking care of patients that came down with this disease. It's different also in the fact that it's more infectious, as we mentioned, but also has a higher case fatality rate than the 2022 clade 2B. As we said, it's spread by close contact, so sex definitely. As we showed, 88% of those people in the hospital got it because of sexual contact, ostensibly, but there were some that got it from other means. It's hard to get it through respiratory contact, as it said, about 4 hours for contact and droplets. This is a little different than being airborne. Just be aware of that. We talked about how vaccination is a factor, how unfortunately 70% of the people who are getting infected and dying are children and do not have immunity to smallpox because of vaccination policies. But also realize that we looked at the case control study that I'll put the link to that states that even after 2 doses, the efficacy is around 66%. And finally, that Africa needs resources to be able to handle this, otherwise its problem is going to become a global problem. So I hope this was helpful. Usually I develop these thoughts a little bit more carefully and along longer lines, but I wanted to get this information out there because this is what's going on and people have questions. I think we will do some follow-up on this, especially as things go, and keep a track on this. Please subscribe, turn on notifications, and join us at medcram.com. Thanks for joining us.